So welcome everyone. Our first speaker for this phase 2 session will be Claude Menard from our Lakesoft division, and I will turn this over to you.
Thank you. I'm going to show you today a study based on a real case from one of our customers. The goal was to optimize sample size of a phase 3 clinical trial using simulations based on a phase 2 population PD model. So this is a very nice example of a modeling and simulation workflow that is quite easy to run with the Monolix suite and answers a concrete clinical question. So in this case study, we will compare two treatments for asthma. So we have a reference treatment, which is the current standard of care, and that is approved for the treatment of asthma globally, including in China. And we have a new treatment that is under investigation in China, and that was recently approved by FDA for treatment of asthma. So it has already been evaluated in terms of efficacy and safety in a randomized, double-blind, active controlled phase 3 study, but on a majority of white patients and with no Chinese patients. So now the evaluation of the new treatment still remains to be done in Chinese patients to support a planned submission in China. So usually this should be done with a clinical trial with a sample size of around 400 subjects by treatment arm. But to optimize the cost of the study, we would like to plan instead a bridging study for Chinese patients with a relatively small sample size. So less than 100 individuals per treatment arm, if possible. And to plan this bridging study, we leverage the data from the phase 3 study that was already done to predict which sample size will really be required for Chinese patients to show successfully a difference in response between the reference and the test treatment. So first, using Monolix, we will build a longitudinal model from the phase 3 data already available on the reference and the new treatment with no Chinese patients, and from this phase 2 data for the reference treatment in Chinese patients only. And I will present this data in detail in a few minutes. So the goal is to get a model that captures well the three data sets such that we can assume that this model can be used to extrapolate to the Chinese phase 3 study. This model should take into account the impact of the covariates, in particular those that may vary between different populations, such as race, weight, height, and so on. And the second step will be to use this model to simulate new situations with Simulx, the application of the Monolix suite for clinical trial simulations. So we will first predict the potential response to the new treatment in Chinese patients, and then we will evaluate the impact of the sample size for the Chinese phase 3 study. So note that this type of bridging strategy is quite new, so there is a slight risk that the China FDA, so NMPA, may actually require additional supportive analysis. So here is what the dataset looks like in Monolix. The measurements are the forced expiratory volume, so the maximum amount of air that one can forcefully exhale in 1 second. And we took advantage of the flexibility of the plots in Monolix to easily choose a layout that splits the data into different plots for the different treatments and for the different studies. And we show the race with colors. So the data set is quite big, so I have chosen to display the data with dots rather than spaghetti plots, and the mean and SD curve appears here in white. So on the top, you have the data from the two phase 3 studies in non-Chinese populations with mainly white patients. And the largest studies has measurements during 6 months, while a smaller one has measurements during 3 months. The patients have received either the reference treatment or the reference treatment with a lower dose, or the test treatment at a lower dose. And the last option was a placebo. At the bottom here, we have the data from the two phase 2 studies in a majority of Chinese patients. And so here you see that we do not have any data for the test treatments. And they have received either placebo or the reference treatment. So difference between conditions is not very obvious here, but the model will show more clearly differences later on. Monolix also provides plots for the covariates. So here I have compared the distributions of most of the covariates across race modalities to check whether there are wide differences between Chinese and non-Chinese populations. So BF-EVPD, this is a marker of asthma severity, and FEV1BL is the baseline in the forced expiratory volume, which is our observation. And in addition here, we see the counts of subjects in each category of race. So overall, there are some differences. In particular, you see here for the weight baseline, there are some differences, and also for the baseline of the expiratory volume. So thus, I should specially check whether these covariates have an effect on the observations and should be included in the model, because in that case, they will also impact the clinical trial simulation, for which I will have to make sure to simulate patients with distributions characterizing a Chinese population. So let's now have a quick look at the longitudinal model used to capture this data. So here is the content of the model file used in Monolix with the adequate syntax. So it's a simple equation that defines an exponential model with A, the baseline, and you have the gain representing the asymptotic improvement. And TD is the time constant, which determines the time that is needed to reach steady state. So we also have a parameter gamma that enables to obtain different shapes for this observation. And the output is the variable E. So this output should stay positive because it is a volume. So we enforce positivity with the maximum function here. So on top of this structural model in Monolix, we also try to explain part of the inter-individual variability in these parameters. So the parameters are here, and they have an inter-individual variability that we model with distributions. And this variability can also be explained by some covariates. So in particular here, the treatment, so TMT is for the treatment, and it's actually not used in the structural model. So the differences in effect between the treatment groups will be taken into account as covariate effects. So this is my final statistical model in Monolix, and there are actually more covariates than initially because we have here the log transform covariates that center the covariates around the typical value and do the log transformation. So I use the Monolix proposal to include relevant covariate effects into the model until no more adjustments were suggested. And as I mentioned, the different treatments are encoded with this treatment covariate, which has an effect on G, the gain. This is the parameter that means improvement in expiratory volume. And based on the estimated parameters, it is possible to calculate different typical values for G in each treatment group. So you see that there are differences between treatments. And in addition, you also have a race, which has an effect on A. So this is the baseline. And we also have actually the baseline expiratory volume. We saw that this is a covariate that differs between the different population, and it also has an impact on A. So now here I show the visual predictive checks that compare predictions based on the model with data. So we see the empirical percentiles as blue curves, so blue whitish curves, and the corresponding prediction as intervals, as colored areas. And we see that the model captures well the data in each group. So we predict the main trend and the inter-individual variability quite well. So at this point, I have estimated a model that seems to capture well the typical trend and variability in the data. So I would like to use this model for further predictions. And in Monolix, the predictions only reproduce the same situation as we have in the data by resimulating the data set. So I cannot have here predictions for the new treatment in Chinese patients. So what I did is I exported my Monolix project to Simulx, where I will be able to simulate new situations. And this leads us to my second part that I did by using Simulx. So simulating and analyzing the clinical trial is done in 4 steps in Simulx. And now I will start with the first step, which is to simulate a new population of Chinese patients. So the elements should be used for the simulation should be chosen very carefully to represent well the desired population, here a population of Chinese patients. For this, I will need to choose appropriate covariates, and I will also have to choose a first sample size to try. So I can start with 75 patients, for example, and I decided to start with 2 possible durations of 3 or 6 months because I don't know what is better. I will show you the first step in the Simulx interface to show you how it looks, and the other steps I will show you them to you on slides because I do not have that much time. So this is how the project looks like right after exporting the project from Monolix to Simulx. So all elements are automatically imported in the definition tab, and if I run the default simulation here in the simulation tab, Simulx will sample new individual parameters from the population distributions that we estimated in Monolix, and Simulx will also reuse the same covariates as in the original dataset to sample the population parameters. I want to define instead 2 new covariate elements instead of using the covariates from the dataset. So I'll go to the definition tab in covariates, and I want to define elements corresponding to new Chinese populations treated either with the reference or with the test treatment. To do this, I will duplicate and modify the elements that was imported from Monolix, because like this, I can reuse the distributions derived from the dataset for covariates that are the same for the different races, so age, height, sex, etc. And to characterize better a Chinese population, I will only change the values for weight, so the weight baseline, and baseline expiratory volume here. So these parameters change a little in Chinese patients and I have seen it when exploring the data. So for the weight, instead of taking 77, I will use 65 for the mean, and for the deviation, I use 11. And same thing. So for the baseline, I will use 1.83. So this is what comes from what I have seen in the data for a Chinese population. And now for treatment and race, what I want to have is a distribution that has only Chinese patients. So I want to have a probability of 1 here to have Chinese patients. And I click on autofill to have 0 in the other cases. And I want to have, for example, I want to have here only the reference treatments. And therefore, I set 0 for all the other possibilities. And I name this covariate reference Chinese, because it's only Chinese patients receiving the reference treatment. I duplicate this one again to have the same thing, but for the test treatment. And I change here, I do not want to have the ref treatment, but the test treatment. Okay, so I have these 2 new covariate elements that I'm going to use in the simulation. But for the simulation, I also need to have a new simulation output to compare the 2 study durations, 3 and 6 months. So I create a new output element, and I use this variable y, it corresponds to observations with a residual error. So I want to focus on the change from baseline at the end of the study. So I will limit my grid to the 2 time points 0, and so 0 for the baseline, and 84 days for a 3-month study. And I will name this output 3 months. And I do the same as I duplicate it to quickly define another output after 6 months. Okay, so I have now my 2 new elements for outputs. So now if I go to the simulation tab again, I can select these output elements that I just created and compute them instead of the original element that was here. And I will create 2 new simulation groups because I need to have different covariates for the reference treatment and for the test treatment. So I rename my group ref and test. And now I select a sample size. Let's say we start with 75 patients. So all these elements are shared between the groups. So each group will be, for each group, we will simulate 75 times the model. So I run the simulation. And now I obtain in the plots qualitative comparison. So these are the simulated distributions for the two groups, the reference and the test treatments. And this already shows that there is an advantage for the test treatment over the reference treatment. But this is just a visual impression, and I would like to post-process this data quantitatively and create outcomes and endpoints to be able to know if this is significant. So what I have done for the following steps has been done with this tab, outcomes and endpoints, but now I will show you on slide what I have done to make sure I stay on time. So the next step after simulation is here. So the step is to analyze the simulated clinical trial data with post-processing in the same way as the true data will be analyzed in the end. So I will derive an outcome, which is a quantitative result for each simulated individual. And in this case, the outcome will be the change from baseline in exploratory volume. So I defined this change from baseline quickly in Simulx. And I defined it at 3 months for the 3 months and the 6 months case. The outcome is then summarized over all individuals automatically in each treatment arm with an endpoint, which in that case, I selected the mean change from baseline. To compute the outcomes and endpoint, I did not have to run the simulation again. I just ran a specific dedicated task, which is much faster. So the post-processing shows quantitatively here the difference between the two treatments, because you see here that the test treatment has a higher mean change from baseline after 3 months and also after 6 months, higher than the reference. So the next step now is to define a formal group comparison criteria to see if this difference is significant. Because sometimes, so this is higher, but you're not sure if this is really significantly higher. So, so you can do that in Simulx as well easily by checking a box for group comparison. And a t-test is done in that case to check the significance of the difference between the groups. So in our case, the difference is significant for a 3 months and for a 6 month study. And you see that there is not a big difference in the statistics, so in the difference between groups in the two cases. So probably it looks like I should be okay with a 3 month study. But we need to realize now that this result is calculated for one population. And if I run the simulation again in the same way, I will get a slightly different result because I will simulate different individuals from this population. So as a final step, it is necessary to check in the end what is the probability of having a successful trial given the random variability in the population. So to calculate the spread of the endpoint value over due to the variability between individuals, instead of running a single trial, I will use replicates. So you can also do that easily in Simulx by choosing replicates instead of single simulation. And I chose 300 replicates. And here, so what I obtain, now that each group is simulated 300 times, I obtain the power of the study, which is the probability to see a significant improvement with the new treatment, which is 78% for a 3 month study and 83% for a 6 month study. So just a bit, so this 83% is good, but let's say it's just a bit low compared to what I want, which is to have at least 85%. So this means I will need more individuals in each treatment arm to have a more significant result. So in that case, I will increase the sample size. And to find the optimal sample size, I need to repeat all the steps I did so far again. So I could modify the group size in the Simulx interface, run the simulation again, check the results, so compute all outcomes and endpoints, etc., and repeat it again with another sample size until I find an optimum, but this will be a bit tiring. So a more convenient possibility is to take advantage of our API for R to script the simulation. And with a simple script, I will be able to test a large list of sample sizes. This API is available with the R package Lixoft connectors, which comes with the installation of the Monolix suite, and it contains a list of functions, so like R functions, that allow to create, modify, or run a Monolix or a Simulx project directly from R. So you can use it like this in this script to test any sample size, simulate the corresponding groups in a loop. You have a for loop here, and you get the table, the results in an R table. And here I show only the beginning of the script because the rest is just post-processing to compute endpoints. And actually here you have also more flexibility to compute whatever outcomes and endpoints you want because you can do that with R. So I have tested all these sample sizes, and we see that the more individuals you have in the study, the less variability in the mean change from baseline in each arm, which makes the difference between the two arms more statistically significant. So here we see the power of the study with respect to the sample size. And you see actually that you need, so the conclusion is that to reach a probability of 85% to have a significant difference in one clinical trial, I need to have at least 80 individuals per arm if the study duration is 6 months, and I need to have at least 90 if the duration is 3 months. And these numbers are much smaller than what we would do if we were not studying this sample size optimization a priori. So to summarize my talk, we found the optimal sample size of a bridging study to validate a new treatment in the Chinese population. And this study was very fast because we used elements imported from the Monolix project, like the model and the covariate distributions. We used Simulx features such as groups, outcomes, and endpoints to compare and analyze different trial designs. And Lixoft connectors enable to systematically optimize the sample size and repeat all these steps in a systematic way to find an optimum around 90 individuals per arm for a 3-month study, which is much lower than the standard 400 individuals per arm that we would have chosen by default. Thanks a lot for your attention. I'm happy to answer questions.
Thank you very much for the presentation. That was very nice and demonstrates the power of phase 3 trial design from models. Can you speak very briefly? We have just a couple of minutes. We have 5 minutes left, I guess. If anybody has a question, 4 minutes, yeah. If we have any questions, you can put them in the chat window and we'll try to address them quickly. But if you have just a second, could you address maybe the kinds of endpoints and statistical tests that are available in Simulx for doing these sorts of simulations?
Yes, so actually I have a slide for this. If it's, I can show it. Yes, so you have automatic, so in the Simulx interface, okay, I don't have it here, but you have automatically the correct test that is selected depending on your endpoint. So if, so here's a table that shows all the tests that are performed in Simulx. So I mean in the interface. So depending, for example, for continuous outcomes, if you have a geometric mean, you will have paired or unpaired t-test depending on whether your individuals are the same or not between the groups. And you have also all these other tests depending. So if you have an arithmetic mean, for example, in that case, it's the same thing. The median is a Wilcoxon test. And then for time to event data, for example, time to event outcomes, you would have log rank text. So all this is summarized in our documentation. And if you need to do a different test, you can always use the connectors to generate the data and then do whatever test you want on it.
That's great, thank you. So we're right at the end of our time. I don't see any other questions yet. If you do have questions as we go through the speakers today, please use the Q&A chat that's available in Excel events, and we'll try to address those at the end of each talk, time permitting. But thank you very much for the presentation today. I guess we have about 3 minutes.
Okay.
So
I stopped sharing, sorry.
okay, that's right. I guess one quick question would be, as we perform modeling and simulation to address a concern for a clinical group who's trying to plan and approve that phase 3 study design, do you have any quick comments on, how do we communicate confidence in the model results? What do we need to think about to communicate confidence in that design that we've simulated?
So you mean how to communicate it?
Yes.
Yeah. So one important thing that I didn't show here is that you have actually uncertainty on the population parameters of the model, and this will also have an impact on the simulation, on top of uncertainty, of course, on the model structure, etc. So on the model structure, you can just say which structure you used and how it was fitting. But for the standard errors, we actually can also use the Elixir flow connectors to create elements that propagate these errors and enable to have a simulation that takes into account this uncertainty.
Okay, great, thank you. So if we will, I think folks can sign out of this session and begin the next track. The next talk in this track, which will be Sebastian Burel, who will be giving us more of an overview of phase 2 kinds of study designs. And thank you very much for the talk today.